Imagine, it's a typical day in the Temple Emergency Department. It's 1 p.m., and so far you have successfully intubated a distressed patient, completed all core measures for a patient with severe sepsis, and treated 5 different patients with possible STD exposure. You're starting to congratulate yourself on being such a rock star when you hear that undeniable yell, "Trauma, Eval." You look over and see a patient sitting upright on a stretcher surrounded by EMS, shaking his head with his seat collar on, and wonder, why does this patient need a trauma eval? Well, let's review. A patient enters the emergency department and is first evaluated in triage. If the patient has a single or multi-system injury with concern for hemodynamic, neurologic, or vascular compromise, then a trauma evaluation by a physician is required. Additionally, a trauma evaluation will be required for special circumstances, which include pregnancy, autoverse pedestrian or bicyclist, anticoagulation or bleeding disorders, motorcycle accidents, and EMS transports who are boarded and collared. A trauma evaluation is generally not required for patients with an injury more than 24 hours old, for motor vehicle collisions without rollover, significant damage to the vehicle per EMS, death of a passenger in the vehicle, ejection from the vehicle, or loss of consciousness. For falls from sitting or standing, where the patient has a GCS of 15, for head injuries without intoxication, altered mental status, loss of consciousness, or a suspicion of a skull fracture, or for extremity injuries without suspicion of vascular or neurologic compromise. Remember, any patient who requires a trauma evaluation should not be sent back to the waiting room. So, this patient had been screened at triage and made it to the charge nurse station for evaluation. Now it's your turn to decide if the patient needs to be rushed off to the trauma bay for further evaluation by a herd of surgeons and get pan scanned, or if he can stay in the emergency department for his care. How do you decide? Imagine you're by the charge nurse station. If you squint your eyes and look really hard past the EMS stretcher, you find this. A patient meets criteria for a Category 1 trauma activation if they have abnormal vital signs such as a systolic blood pressure less than 90, a heart rate greater than 120, a respiratory rate less than 10 or greater than 29, or airway compromise, if they have a GCS less than or equal to 13, or if there are lateralizing neurologic signs or traumatic paralysis. All penetrating injuries to the head, neck, torso, and groin, or to any extremity where there is suspicion of vascular compromise, and all patients with major amputation, burns of more than 20% body surface area, and transfers from other facilities who are receiving blood to maintain vital signs meet Category 1 trauma activation criteria. Also, any pregnant trauma or patient older than 65 meeting Category 2 criteria, or any patient who meets 2 or more Category 2 activation criteria will be a Level 1 activation. If a patient doesn't meet criteria for Level 1 activation, then look here. Criteria for Category 2 trauma activation includes clinical evidence suggesting a serious closed head injury, intra-abdominal injury, or pelvic ring fractures, fracture of 2 or more proximal long bones, such as the femur and the humerus, multiple rib fractures, bleeding disorders or patients on anticoagulation, fatality of a passenger in the same vehicle, ejection from a vehicle, a motorcycle crash at more than 20 miles per hour or rider separation from the motorcycle, or a fall of more than 15 feet. If a patient doesn't meet these specific criteria, but you still think a trauma activation should occur, a Category 1 or 2 trauma activation can also be determined at the discretion of the attending emergency physician. Back to your patient. EMS tells you he's a 66-year-old man with no medical history, not on anticoagulants, who was a restrained front seat passenger in a low-speed motor vehicle collision. There was no airbag deployment, no deaths in the vehicle, and the vehicle did not roll over. The passenger hit his head on the dashboard and lost consciousness. He has a hematoma on his forehead. He is awake, alert, and oriented, and has no neurologic deficits. You thank the EMS personnel for their incredibly clear description of the situation and decide that this patient does not meet criteria for trauma activation. But he has a potentially dangerous head injury and might need a CT scan. So you pull up the Canadian CT head rules to help you decide if he needs imaging. This rule says that a CT head is only required for minor head injury patients if they have one of the findings that would place them at high risk, meaning they may need neurological intervention, or at medium risk, which means there would be signs of brain injury on CT scan. High-risk findings include a GCS score less than 15 at 2 hours after the injury, suspected open or depressed skull fracture, any sign of basilar skull fracture, such as hemotympanum, raccoon eyes, CSF otorrhea or rhinorrhea, or battle sign, 2 or more episodes of vomiting, or age greater than 65 years. Medium risk findings include amnesia before impact of 30 or more minutes, a dangerous mechanism, such as a pedestrian struck by a vehicle, ejection from a vehicle, or fall from elevation of more than 3 feet or 5 steps. The Canadian CT head rule does not apply to patients who have no history of trauma, have a GCS less than 13, are on anticoagulants or have a bleeding disorder, are less than 16 years of age, or have an obvious open skull fracture. You decide that the patient meets criteria for a CT scan of his head, but you want to get it quickly in case he has a clinically important traumatic brain injury. This is the basis for the Rapid Head Protocol. The purpose of the Rapid Head Protocol is to expedite the care of patients who do not meet trauma activation criteria but may have isolated traumatic brain injury with or without associated cervical spine injury, and to screen for trauma activation criteria by focusing on a thorough clinical assessment by enlisting ancillary staff to expose, log roll, register, and transport the patient. Inclusion criteria for the Rapid Head Protocol are head-injured patients with CT imaging indications with a GCS of 14 or 15 not meeting trauma activation criteria, or patients with an unclear head injury history, but with other factors that raise the emergency physician's index of suspicion for intracranial hemorrhage, for example, the intoxicated or elderly patient. Exclusion criteria are patients who meet any trauma activation criteria, including GCS less than 14, although limited chemical control of agitation is acceptable, and patients with evidence on exam and/or a mechanism to suggest serious multisystem injury. Once the Rapid Head Protocol is initiated, the patient will be assigned a room, and the resident, nurse, PCA, and registration clerk will convene as a team at the bedside. The resident will perform a primary and secondary survey for trauma, place orders, and inform the CT suite of a Rapid Head patient needing immediate imaging. The PCA transports the patient to and from the CT suite and informs the physician upon return to the emergency department. The CT scans should then be reviewed and discussed with members of the treatment team. You say, "Let's get a Rapid Head CT scan," and suddenly the emergency department snaps into action with you, nurses, PCAs, registration clerks, and CT techs getting this patient ready for his scan. The patient's head CT comes back negative, and you give him some Tylenol and an ice pack for his forehead, and a turkey sandwich before he goes. Another successful trauma eval completed. But what if instead of 66 years old, this patient was only 6 years old? All trauma evaluations and activations, regardless of age, occur in the adult emergency department. Again, perform a brief history and physical exam and determine if the patient meets any of the criteria for Category 1 or Category 2 trauma activation. If the pediatric patient meets criteria for trauma activation, patients less than 15 years of age will be resuscitated in Trauma Bay 3. Patients 15 years of age or older will be resuscitated in Trauma Bay 1 or 2. For kids less than 14 years of age with a head injury and GCS of 14 or 15 that don't meet trauma activation criteria, another set of guidelines specifically for pediatrics can be used to streamline management. This includes patients with repeated, persistent, or progressive vomiting, loss of consciousness, history of lethargy or irritability, now resolved, high force mechanism or fall onto a hard surface, hematoma, especially if large and non-frontal, unwitnessed trauma with possibly significant mechanism, signs of skull fracture, bulging fontanelle, suspicion of abuse, or an underlying condition predisposing to intracranial hemorrhage, such as von Willebrand's disease or factor deficiency. These guidelines are based on the PCARN study of pediatric blunt head trauma. The PCARN study was published in 2009 with the purpose of creating a clinical decision rule for deciding who not to get a head CT for blunt trauma. The study enrolled patients less than 18 years of age within 24 hours of head trauma and a GCS of 14 or 15 in the emergency department. The outcome of interest was the identification of clinically important traumatic brain injury defined as death from TBI, intubation for more than 24 hours, neurosurgical intervention, or hospital admission for more than 2 nights. The clinical decision rules are based on the patient's age. Patients less than 2 years old who have blunt head trauma and have GCS of 14, altered mental status, or a palpable skull fracture should have a CT scan since there is a 4.4% risk of clinically important traumatic brain injury with these findings. If none of these are present, then assess for non-frontal hematoma, loss of consciousness for 5 or more seconds, the patient not acting normal per the parent, or severe injury mechanism, which includes a motor vehicle collision with patient ejection, death of another passenger, or rollover of the vehicle, pedestrian or bicyclist without a helmet who is struck by a motorized vehicle, a fall of more than 3 feet, or a head struck by a high-impact object. If one of these findings is present, then the patient should be observed, or a CT head may be obtained based on clinical gestalt, including the physician experience, multiple or isolated findings, worsening symptoms after an observation period, the age of the patient less than 3 months, or parental preference. If none of these findings are present, then no CT scan is indicated. For children older than 2 years of age, with GCS of 14, altered mental status, or signs of a basilar skull fracture, a CT scan should be performed. If the patient has loss of consciousness, history of vomiting, a severe headache, or a severe injury mechanism, which includes a fall of more than 5 feet in this age group, then the patient can be observed or get a head CT scan based on clinical gestalt. If none of these findings are present, then no CT scan is indicated. Now, what about a trauma eval for this patient? These cases can be tough, but again, start with a brief history and physical exam and determine if the patient meets criteria for a Category 1 or 2 trauma activation. If no trauma activation criteria are met, then patients with less than 20 weeks gestation will be evaluated in the adult emergency department. Patients with 20 weeks or more gestation will be transferred to L&D triage. If trauma activation criteria are met, then the OB trauma paging system should be activated. These guidelines for trauma activations are all available in the Temple ED Handbook for reference. So next time you hear the call for trauma eval, you'll know what to do, or at least where to look for guidance.